Hello, let's talk today about hyperthyroidism. Dr. Leibert here. Let's have a little fun. It can be a little complex, so let's first refresh our memories about some of the symptoms of hyperthyroidism. On vital signs, patients will tend to be tachycardic, blood pressure can be elevated. Typically, the temperature is high normal, but the patient complains of feeling tremulous. They may have tremors. They're more agitated, anxious. They're eating like a horse but losing weight. They're always sweating. They may be having diarrhea, GI upset. If they're a woman, they may be having menstrual abnormalities, menorrhagia, or even amenorrhea, not bleeding at all. So some of those symptoms of hyperthyroidism, and you think, I need to do a screening. That's where the TSH comes in, the thyroid stimulating hormone. It's ultra sensitive in labs these days, so it's a great screening tool. Now, you have signs of hyperthyroidism, and the TSH, let's go to the left side of the diagram, and the TSH ends up being high. Oh, that's really wild. Get your free T3 and free T4, and if they're elevated, you have something called central hyperthyroidism. The pituitary tumor is secreting TSH, and it's, of course, stimulating the thyroid. Chances are you'll never see this, but it is an interesting phenomenon. Of course, an MRI of the brain and likely transsphenoidal surgery would be necessary to remove that mass of the pituitary. Likely you'll never see that, but it is a possibility. Typically, signs of hyperthyroidism, you get your TSH, the TSH will be low, and the free T4 and the free T3 then will be the clincher as to the cause. So let's look at possibilities. If the free T4 and the free T3 are low, then you have central hypothyroidism. The TSH is low, both those hormones are low, the pituitary just is not working. Maybe they have an empty sella syndrome, or maybe a Sheehan syndrome for a postpartum hemorrhage causing necrosis of the pituitary. Would they have symptoms of hyperthyroidism? Unlikely. But I put this here just so you see that pattern. Now, more commonly, in the hospitalized patients, the TSH will be low, and the free T4, the free T3 might be low normal. In the euthyroid sick patient, this is this next category in the algorithm, these patients are in the hospital because they have pneumonia, they're septic, maybe an MI, they're in heart failure. Something's going on that's making them sick, the ICU. These are sick folks, and the thyroid is affected by their systemic disease, SIRS, systemic inflammatory response syndrome, if you will. So in that case, don't get crazy about going after their thyroid. In fact, most of the time in sick, really sick hospitalized patients, I don't bother with the TSH unless they have a history of thyroid disease or it's new onset atrial fib, and I've got to know whether they have hyperthyroidism. Otherwise, I avoid getting that TSH unless there's a really specific reason, because the euthyroid sick patient will recover. Their thyroid will be fine. Once they're done with their illness, be it infection, be it some other bodily stress, thyroid's fine. Let's go to the next category. Low, again, they're hyperthyroid clinically. TSH is low, and the free T4 and free T3 are elevated. Okay, now we're right in the center, the heart of this issue. This is where the I-123 thyroid uptake scan done in nuclear medicine is so important. It will now help you to differentiate the cause of this hyperthyroidism. Now, if the scan comes back, and now we're looking down here in the algorithm with increased uptake, then there's three major things that I want you to think about. And this is where most folks are going to end up. Graves' disease. Graves' disease is a disease of 30 to 40-year-old females. Thyroid disease, hyperthyroidism, has a female-to-male ratio of 5 to 1. So it's almost always going to be females. I don't mean to be picking on you, but that's how it is. Graves' disease is an autoimmune disease. One antibody test you can get is the thyroid-stimulated immune globulin, which constantly is stimulating the thyroid to produce T4, which is converted in the periphery to T3. Graves' disease. These patients have the the exophthalmos. They may have extraocular motion abnormalities. The classic triad is ophthalmopathy, a diffusely enlarged non-tender thyroid, the thyromegaly, and also dermopathy, something called pretibial myxedema. See if I can get my old fuzzy leg up here. This part of the leg has a woody indurated edema. That's a classic triad of Graves' disease. If they're older, 60, 70-year-old female, they may have a toxic multinodular goiter. The patients have a lumpy, bumpy thyroid. They're symptoms of hyperthyroid. And that uptake scan will show lots of hot, hyperfunctioning nodules. Or, again, the younger patient, a little more rare, the toxic adenoma. One nodule is hot, just really going to town. So down in this category, low TSH, high free T4, high free T3, elevated uptake scan, Graves, toxic multinodular goiter, toxic adenoma. Now, what if that thyroid uptake scan shows a decreased uptake? Oh, this is interesting. Now you're down in this box way in the right corner. They may have subacute thyroiditis. I've had some really cool cases of subacute thyroiditis. Those patients classically have a tender thyroid. They may or may not have fever. They've had a recent viral illness, influenza, or something they didn't even pay attention to, adenovirus. But they come in and they'll have 4 to 6 weeks of hyperthyroidism, then a month to 6 months after that of hypothyroidism, and then euthyroid. Fascinating, because what happens is the virus sets up some autoimmune process which explodes the colloids, the storage units of the thyroid, causing them to be hyperthyroid. But the uptake scan is low because all those colloids are exploding. It's not like Graves' disease. Then, as all the colloids are worn out, the patients become hypothyroid. And then as the body deals with the virus, this inciting trigger, they finally recover and become euthyroid and normal. There is a small number of patients who stay hypothyroid, but for the most part, they're younger folks and they recover fully. Fascinating. Also known as de Quervain's thyroiditis. A factitious hyperthyroidism is in this category. They're taking thyroid pills, levothyroxine, cytomel, which is the T3, maybe to lose weight, have more energy. Or it's found in these weight loss formulas. They crunch up that stuff into some powder and there's thyroid medicine in there. Wow, you got to really watch that. I had an interesting case of a patient that presented hyperthyroid, and little did she know, or we know, that she had been taking a weight loss powder that had synthroid mixed up in it. Struma ovarii is an ovarian tumor that secretes thyroid hormone. Very interesting. It's independent of the typical thyroid. It's nothing to do with the thyroid gland here. It's actually a distant site, sort of a perineoplastic syndrome, if you will. Very rare. And medicine like amiodarone can cause hyperthyroidism, but the uptake scan will be low. The final category is the low TSH and the free T4, free T3 are normal. Now this patient is called a subclinical hyperthyroidism, but by definition, they don't have symptoms. So again, a little difference here in the algorithm. They're typically asymptomatic by definition. So what do you do with these folks? You have to be careful. The elderly with subclinical hyperthyroidism can still go into AFib. AFib is one of those cardiac results of hyperthyroidism that's dangerous, particularly for the elderly. So in the older patient with subclinical hyperthyroidism, often place them on a beta blocker and then follow them every 3 months to see which way the TSH is going. If it continues to go down, it's time for that uptake scan to find out what's going on. If they settle down, and just have a patient this week, 6 months ago her TSH was low, I put her on the beta blocker, she did very well, the TSH is now normalized. It was just a transient abnormality. Was it due to a virus? It's hard to say. So what we've talked about is the workup of a clinically hyperthyroid patient. I hope this helps you. God bless, and remember, we love because Jesus first loved us. It's a great truth. Have a blessed day. Bye now.